endoscopies we're going to use in patients with ankylosing spondylitis to actually see if they have subclinical inflammation. So there's this overlap. So what does this mean in terms of the genes and the pathways, which is your question? It turns out that these genes, now, if you look at the gene products, what do the genes do in terms of turning on cells? And what triggers these genes to be active? Certain bacteria in the gut. These bacteria in the gut, which we all have in our intestine, bacteria live in our intestine. Certain bacteria will trigger Crohn's disease. So Crohn's disease patients have a basic immune dysregulation of their GI tract based on their genes. They encounter a bacteria. That bacteria interacts with cells in the GI tract and explodes and turns on the disease. So what we're doing now is we're going to end up looking for certain bacteria that may trigger ankylosing spondylitis. So why, for instance, does somebody with B27 get the disease and somebody B27 not get the disease? Well, it may be that certain triggers that you encounter in your environment that cause changes in the gut flora. Now, why do we know this is a possibility? Well, we do know that if you are HLA-B27 positive and you go and get a Salmonella or Shigella infection, you hightail it down to Mexico, for instance, and go surfing on the beach and eat the food down at the local place, and you get a Shigella infection, you'll end up getting what's called reactive arthritis. You've heard of reactive arthritis, Reiter's disease. Remember that name, Reiter's disease? Which is one of those diseases that's included in the group of spondyloarthritis. And if you get a huge jolt of these bacteria, these Shigella, and you get this big diarrheal illness, and you're B27 positive, you're going to get reactive arthritis. And of the ones that get reactive arthritis, a third of them will have spondylitis. And those spondylitis patients will go on forever to actually have spondylitis. So we already know that certain bacteria, pathogenic bacteria that we don't normally harbor in our gut, like Salmonella or Shigella, we don't normally have those. Okay? If you get those, you get the disease. Now we're trying to figure out which of the bacteria that we normally that normally live in our gut actually cause ankylosing spondylitis. You follow my reasoning here? Okay. So all of this boils down to the basic paradigm that we talked about earlier, is the relationship between the genes and the environmental trigger. And I brought up to you, I said, well, when does disease begin? You know, when does this actually start? Okay. We don't know. Questions?
I've had an undifferentiated diagnosis for about 11 years, and
which is probably a smart move for the doctor's part. But when you say undifferentiated, you mean do you have spine involvement at all?
No inflammation. Emphasis mostly is on
but unable to.
No cues.
But MRIs are negative throughout your whole spine. Did you have a whole spine MRI, neck, thoracic, lumbar, and SI joints done with a T1 image? Okay. You should be able to demonstrate inflammation using that technique, that tool. That's the first suggestion I would do, is to go back and do that. Okay? And then if you do that and it's positive, your rheumatologist can say unequivocally, this patient has ankylosing spondylitis by MRI criteria, and therefore they are obligated to approve the use of one of these drugs because the FDA has approved it for a specific diagnosis. The reason insurance companies hunker down, well, we know the reason they hunker down, because it's much better off investing their money in the stock market than giving it to you guys. That's what their stockholders want them to do that. It's a free enterprise system, I guess. That's how it works. So that's why they're doing it. So how they do it is restricting access by saying, we will only approve the drug if you fulfill the criteria that the FDA approved the drug for. The problem, of course, in all of this is that the insurance plans, if some of them are very restrictive and only allow the drug to be used for the FDA indications, others are looser and will allow you the use of the drug for things that the FDA did not approve the drug for. Most all of the diseases that we treat today, I treat as a rheumatologist, we use drugs that are not approved for those diseases because the diseases are not common. The drug companies have not done the research to allow the FDA to make those decisions. Most all of the drugs we use, if your insurance company pays for Motrin or diclofenac or Lodine or any of those drugs, and your insurance company pays for it, okay, those drugs are not approved. Okay? Well, they're not as expensive. Okay? So they're breaking their own rules. And then they're saying, well, only the expensive drugs we're going to hunker down. You fight that. I gave you one way, okay, which is to make sure that your rheumatologist has done all the, and most rheumatologists, as Lori said, don't know these nuances of what kind of testing to do for this. So you go back to your rheumatologist and you say, Dr. Weisman said to do cervical, dorsal, lumbar, and SI joints, to do a T1 and a stir image on all those areas to try and document inflammation. And he'll say, Doctor who? A jerk. What does he know in Los Angeles? Who does he think he is, right? So, yeah. Who's your rheumatologist here? Who? I don't know. Well, the Denver Arthritis Clinic is a pretty smart group of people. They should know, these things, and discuss it with them openly, and tell them, that there are, if you can increase the testing, you might be able to demonstrate this. Okay. The more expensive the insurance plan, the more liberal they are to allow you to use drugs that are not necessarily always tightly FDA approved. Okay, so HMOs, one thing versus, PPO, they all have ranges of hunkering down for you. You just got to wear them down. The insurance company mantra: deny, wait for protest. Okay, so you just have to keep going and going and going and going. They don't bother me anymore. When I write something down, because I ask them to look for the guidelines, and they look for the guidelines, and my name's on the guidelines. So they don't bother me anymore.
Let me ask a question, please. Are you accepting new patients?
I do, sure.
You do, okay.
Sure.
Just in case anyone is interested at some point.
Yeah, but I don't live here.
Yeah, but some people are interested.
Okay.
To see a physician.
But I don't live here. Okay, more questions. There's one, two. I think you were first over here on this side.
The anti-TNF therapies, can that get you away from the NSAID therapies with their involvement with the GI problems?
Yes.
So you can get clear of that whole GI thing with NSAIDs, and you don't need to have those with the TNF.
Correct.
Okay.
Correct. Yeah.
And you can get off the Prilosec and which affects the gut thing and all that. Maybe.
As far as I know, there are no real significant GI toxicities associated with the anti-TNF drugs.
Yeah, or stomach irritation, I guess.
Correct.
Yeah. Okay.
Right.
Thank you.
Right. Question.
I was just wondering if you're diagnosed with AS, like say in your lower back, and your rheumatologist says that it's fairly mild as of yet, and they want to put you on the TNF drug, say like Humira, but you're also having other symptoms like in your chest or in your knees or things like that. Is the appropriate route to go just take the drug, it's not that bad yet, and the drug will fix everything else? Or could it actually be worse than what the doctor's seen, and they actually need to x-ray, say, your knees and like your chest and things like that to see if does it kind of start in the back and then maybe stop and spread to other areas of your body, and it's more progressed than what they think it is?
I think I understand your question. It turns out that the anti-TNF drugs do affect other areas of the body other than just the low back, sacroiliac joints. They affect this enthesitis that occurs around the body. There's no question about it. So the question that you should be asking, probably really want to ask, is do these anti-TNF drugs really have an impact on the natural history of the disease? Do they stop fusion? Or are they just controlling inflammation? Is that what you want to know? Right? Well, the jury is still out on that issue right now. We know for sure that anti-TNF drugs do cut down on the inflammation. You can measure that with the MRI. You can measure it with some blood tests. And, of course, you measure it also with pain and stiffness and aching that patients have. That we know. But does it impact the X-ray changes of fusion? This is a very complicated question because the X-ray changes take place very slowly over time. It's very hard to measure. And in studies that have been done so far, the measuring tools that have been used have not shown that the anti-TNF drugs have had an impact on the rate of change of bony change. Now, there's potentially two reasons for this. The first reason is that it doesn't do that. That the bone changes, the fusion that takes place is independent of control of anti-TNF. That there are other cytokines or other pathologic mechanisms that are causing those bone changes that are not affected by the anti-TNF drugs just because you feel better. All right? And there's some experimental evidence that there are some pathways that are not affected by the three anti-TNF drugs that are out there. So that there is some what people call uncoupling of the effect on inflammation and the effect on bone change, uncoupling. Now, the reason this is pursued is because in rheumatoid arthritis, a disease that I know very well, there is no real uncoupling between inflammation and bone changes. In fact, they kind of go together. When you use anti-TNF drugs, you can actually prevent erosions and bone damage and bone change. So the thought is, well, why doesn't this occur in spondylitis? Well, it could be the two reasons that I mentioned, that the spondylitis pathway is not affected like it is in rheumatoid arthritis by the anti-TNF drugs, the pathway to bone change. But the other way is our measurement tools are insensitive to actually see this change. The reason I say that is that there have only been 2 studies published to show that have shown that there has been no change over 2 years when the use of anti-TNF drugs have been applied. Those 2 studies, one was done with Enbrel or etanercept, and the other is done with infliximab or Remicade. Both of them showed the same thing, that in spite of the fact that patients stayed on these drugs for 2 years and they felt really well, the bone changes in the experimental group that were the same as the bone changes in the control group, which were patients not treated. However, the control group was mismatched. It was not a real control group. It was a control group that these doctors had up their sleeve. And they had been studied years before, and the data had been collected years before. It was what we call a non-contemporaneously collected control group. And because there was a problem with the methodology, That is, the control group wasn't really a good control group. It wasn't really a good control group. It was not as active, for instance, as the ones. It was not as active a disease as the ones that got the anti-TNF drugs. So if the control group was not as active, their progression would have been much slower, right? So that if you slow the progression of the active group and compare it to the other control group, they'll look the same, right, from a scientific standpoint. So these studies were criticized in a major way that perhaps the methodology of detection of progression was not appropriate. So this is a long-winded answer to your question, which is my question, about the natural progression of the disease, is that our detection systems have not been good enough or sufficient to be able to answer the question. Now, currently, we're doing much better. Currently, we're using MRI in conjunction with another very sensitive X-ray look to see whether or not that there really is a change to eliminate the bony changes using anti-TNF drugs. So maybe we'll know and maybe we won't.
But is it reasonable to expect that your doctor, rather than just diagnosing you with AS by an X-ray of your back, is it reasonable to expect your doctor to go the next step in that if you're having other symptoms of AS, that he goes and X-rays those various parts of your body to see how progressed the AS is? Because I'm assuming you would see some sort of difference in the bone in your chest and things like that.
Yeah, and using MRI is a better way of doing it than X-ray.
Okay. So if they say MRI is just an expensive way to do it, X-ray works fine. It's reasonable to expect that
I
they
can't
would
answer.
then.
I mean, the specific question I can't answer, but I know that the MRI. An MRI is not an X-ray. You have to understand this. An X-ray is like taking a photograph, a picture